Hello, once again Ijazi Dayat is with you with, as you know, with new topic, with new discussions, and hope you are enjoying my talk. And we are here to just get some knowledge, and we are sharing our knowledge among our Proficient community. So today's the topic of my today's talk of discussion is Autologous blood salvage. I have no conflict of interest. Truly, this education is based for to enhance the knowledge of Proficient community and share our experience among the Proficient group. So the objective of my today's topic is to just highlight the history of the blood cell salvage, clinical usage, principle of the autologous cell salvage, indications, type of autotransfusion, advantages and disadvantages, and hope will come up with some good conclusion. Is cell saver is beneficial for to use to reduce the or minimizing the blood transfusion? Is this blood cell saver is the blood conservation good technique or not? So everyone have their own experience and have their own views. So everyone have full rights to say whatever they experience and what they feel. So definition of the autologous blood transfusions is that we are collecting the patient's blood, and we collect it, we washed and re-infused back to the same patient. So mean patient's own blood which was collected, which was processed, where we just wash the red blood cells, wash back cell, and re-infuse back to the same patient. So this is called autologous blood salvage technique. What is the other technique? The other is allogenic homologous blood transfusion technique. So allogenic blood transfusions mean that we are getting the donor's blood and giving to the recipient. So this is called the allogenic blood transfusion. But today we are talking about the autologous blood transfusion. The history I will not go through in a deep, just for just to refresh. The first time autologous transfusion was performed by Dr. James in London in 1818. Before and this happened before the discovery of the blood groups. This was happened before the discovery of the blood group. And the first time the blood salvage was reported in American literature in 1917. And in 1932 the first blood bank was established. And in 1943 the cell saver device was developed, and in 1974 onward the cell saver system was introduced and started uses in cardiac surgeries, in a surgery where the patient required to bleed more, and we try to minimize, and instead of the wasting the patient's blood, we just suck out and process it and collect the wash back cells and re-infuse back to the patient. So this is the history of the cell savers or the cell salvage of the during the any surgery. So when we where we can use this cell salvage technique, or where we can use the cell saver, its clinical uses will be in a different surgeries like a cardiac surgery, vascular surgery, trauma surgery, orthopedic surgery, and even liver transplantation. There are 4 phases of the cell salvage principle. First is to just we collected the volume, separation the volume, wash the volume, and then the fourth is re-infuse the volume. The volume which we collected from the surgical field, of course, in this volume, the bleed blood having the plasma and formed element cell. In a plasma, as you know, there is a 55% plasma. In a 55% of the plasma, you have the water, protein, electrolytes, and lipids. And in formed elements, 45%, where we have the red blood cells, we have the white blood cells, we have the platelets. So what we are collecting? Red blood cell. Why? Because it is the necessary and important for during the surgery for transportation of oxygenation to the tissue. The principle of the cell salvage is density of the blood components like a plasma, leukocyte and erythrocytes. So they have the density level which I can decide. Like a plasma we have 1.025 to 1.029 gram per cc, leukocyte have 1.065 to 1.09 gram per cc, erythrocyte having 1.089 to 1.097 gram per cc. So these are the density. So the principle of the cell salvage is like a centrifugal force, separate these components relative to their respective densities. So the higher density component will move faster from the excess of the rotation than those have the lower density. Whenever we suck out the volume from the patient field to the reservoir and we start to processing, we always keep at least 150 mils of the anticoagulant volume in the reservoir. And during the collection, we always keep running the drip, the wash which is already connected to the anticoagulations, like 13 to 50 mils per 100 ml of the collected bags. So we added and we always running this in the systems. So there is a three type of autotransfusions. One is the pre-donation, acute normovolemic hemodilution, and intraoperative and post-operative blood recovery. So pre-donations mean the patients who need to know, the patient knows that he will going for the surgery and he required blood. So the blood was collected pre-surgery from the patient's own, and then we can say the pre-donations, the patients planning elective surgery, as I mentioned, requiring blood transfusion may be able to donate blood from themselves prior to surgery. And ANH means it's the blood conservation techniques, like we have the different techniques where we try to minimize the transfusion of the blood. And with the maintenance of the normovolemia during the bypass, by adding the crystallide or by adding the colloid, we are avoiding to add blood to the patients. So what are the intraoperative blood salvage, as known as the autologous blood transfusion, or we can say the cell saver? So three phase: pre-operative, during surgery, mean intraoperative, and post-operative. So cell saver can be used pre, intra and post surgery. So there is a type of autologous cells, the cell processor, then direct transfusion and ultrafiltrations. So cell processor means the salvage device is like a washed and save the RBCs. In a cell, so what we are doing, we are washing the red cells, separate from the rest of the component, and we transfuse back to the patient. This is called the cell processor. Direct transfusions mean the blood which we are getting from the surgical feed into the cell saver without processing. We suck back into the heart-lung machines, like we have the cardiothoracic reservoir. So that without processing, just getting and returning back to our whole system of the cardiopulmonary. Ultrafiltration is one method where we take a whole blood and remove unwanted excess non-cellular plasma, water, low molecular weight solutes, platelets, inhibitor, and some particulate matter through the hemoconcentrator. So now we'll talk about the preparation of the cell saver. For preparation of cell saver, of course, you need a cell saver machine, console, cell saver kit, and aspiration kit. This is from the kit which we are sucking from the tube, which are sucking the volume from the surgical side, returning back that bringing that volume into our cell saver reservoir, and from there it is going into the surgical in a process where we have the centrifugal pump, where we're centrifuging and separating the red cell and just pushing back into the bag, which bag is going to connect to the patient for re-infusion. The blood is collected from the operating field and draining site. Blood mixed with the anticoagulant and collected in the disposable reservoir with the filter, as I mentioned. So the most important thing which I need to highlight here, that the volume, anticoagulant volume, the heparin amount in a normal saline, in a liter of saline, should be not less than 30,000 units in 100,000 mils of saline. So it can be 30 to 50,000 international unit of heparin in 1 liter of saline, or if you're using 500 ml of anti-flush, so you can add 15 to 20,000 unit of international unit of heparin in a 500 bags. The blood is collected from the operating field and draining side. Blood is mixing with the anticoagulant mentioned and collected disposable into the reservoir with the anticoagulation solution. So what is happening when we collect the volume? So it will going to process in a centrifugal pump. The centrifugal pump speed is all around like a 5,000 RPM to centrifuging the cells, making separation of cells from the rest of the volume. The wash with the saline is, of course, for us we need some solution to wash and make a separation of the red cells. So we are using the normal saline for this, for washing of the cells. Most of the WBC and cell fragment and the activated clotting factor are laminated into the waste bag. Keep in your mind, don't go more than 180 millimeter per mercury of your vacuum. So always keep the vacuum below than minus 180 millimeter per mercury. If you're exceeding more than minus 180, it will going to lead for destruction of the cells. So ideal suctioning should be, negative pressure should be in like a minus 80 to minus 120 millimeter per mercury. This is the ideal, but you can increase the negative pressures for the suctioning pressure to 150, even sometime if you have a huge amount of volume in your cavity, you want to suck fast. But this is for the couple of minutes, not to continue. And don't forget this, the timely to sponging and rinsing of the isotonic solution, and always keep the drip of your normal saline, which is with the anticoagulant, like 14 to 15 drop per minute. Just fix the rate of anticoagulation for during your surgery. What are the substances which are going to be washed out during the process? Plasma, platelets, white cells, anticoagulant solutions, plasma-free hemoglobin, cell stroma, activated clotting factor, intracellular enzymes, potassium, plasma bond antibiotic, cytokinase. These are the things going to be washed out. And what is the indications? Indication for usage of the cell saver is if there is a loss of more than 1,000 ml of blood from the patient side, or 20% of the volume of the patient is going to bleed, you can, yes, this is a recommendation to use the cell saver. If your hemoglobin the lower side, if patient is anemic, yes, you can use the cell saver. If there is a patient having the risk of bleeding, like aneurysmal or dissection cases, yes, you have to use the cell saver. Patient having unusual antibodies and blood types, you can use the cell saver. Patient are declined to transfuse from the allogenic blood, so there is an indication to use a cell saver machine. There is as I mentioned, this is the indication of by using of the cell saver. The devices which having the advantages, of course there's disadvantages also. So I'll just go through with the first advantages, then we'll go to the disadvantages. The advantages: acute hemolytic reaction due to the ABO incompatibility, to avoid the complications. So what is happening? To avoiding the complication associated with the allogenic blood transfusions, so there is the much advantages. So if you're going to use the allogenic blood, there is a chance of acute hemolytic reactions due to the ABO mismatch, alloimmunizations, allergic and febrile reactions, transmission of infectious disease like HIV, hepatitis B and C, malaria, immunosuppressions, conservation of the blood resources, rare blood phenotypes, availability require no cross matching. So with the usage of autologous, and you are safe from all these points. But if you're using the allogenic blood, there is a chance of all this which I mentioned, the factors. So we are eliminating all this factor by using the autologous blood cell. Disadvantages, of course, eliminated or activated clotting factors. So if you're using the cell saver, you have to focus on your ACT, So to keep the clotting factor and the happening in an ACT in a normal range. Number two is a cost effective. So of course, by using the cell saver, you are going to increase the cost of the package of the surgical package of the patient. So incomplete washing can lead to contamination with the activated leukocytes, cytokinase, and other microgrades. So we'll come up with the conclusion of the usages of the cell saver. It is important to weigh up the risks versus the benefits in each case in order to make the appropriate decision. This is number one. Number two is autologous blood transfusion, when used appropriately, can provide a safe alternative to allogenic blood transfusion. Number three, there will always be a need of allogenic blood. Even patients who have autologous blood still keep a backup allogenic blood available in a blood fridge, so in case you need, you can use it. Ensure the usage of the safe blood regardless resources. So this is the total conclusion of my talk. Is cell saver is beneficial for the patient to reducing the risk like contaminations. It can be helped to reduce the manpower. It will be time effectively, better healing of the patients, and of course reducing the cost. Have a nice and good day. Take care. God bless you.